Well, good afternoon, everybody, and welcome to Behind the Discoveries, new technology to prevent heart attack and strokes. My name is Matthew Keenan. I get to be the host this afternoon, and I'm looking forward to talking about this topic to Professor Karlheinz, who's one of the Deputy Directors at the Baker Institute. Before we get started, in the spirit of reconciliation, the Baker Institute acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We pay our respects to their elders past and present and extend that respect to all Aboriginal and Torres Strait Islander people today. In terms of why I'm here and I'm an ambassador for the Baker Institute, if you didn't join me for the previous Behind the Discoveries, it's pretty simple. I'm here as somebody with great self-interest. We see a huge amount of fatalities each year in Australia and around the world due to cardiac disease. And my family has been heavily impacted by that, including my grandfather and two uncles on my mother's side of the family, all dying of heart attacks in their mid-40s. And just in the last 18 months, my father has had two heart surgeries, one for his pericardium, which had started to go a little bit hard at 83 years of age, and another one just a few months ago where he had a stent put in. So that's why I'm here, and I'm really keen to learn more about today and the topic that we're talking about with new technology to help prevent heart attacks and stroke. In terms of where you're at, for a little bit of housekeeping, your microphones will be muted throughout the duration of the webinar. Please note that this is being recorded, this webinar, for research purposes for us as well, and certainly looking forward to hearing your questions. Please submit your Q&A, your questions to the button which is down the bottom. It's reasonably easy to be able to spot. And if you can use the chat function, if you do have any technical difficulties. And on the topic of the chat function, given that we're here talking about research, we'd love to hear from you where you're tuning in from and why you chose to listen to this webinar. So we get a bit of a feel afterwards for the audience and what brought you here, and it will help steer us in terms of the topics that we tackle in the future. I'd also like to thank the sponsors of this event, AIA Vitality. They're helping make this event happen. The work that we're going to talk about today is some significant work that has been done by Professor Karlheinz. He's a Deputy Director of the Institute, and when he's not doing that, he's riding his bike to work, and sometimes I get to bump into him on Kew Boulevard when riding his bike, but he's playing an important role at the Alfred working as a cardiologist. Karlheinz, welcome to your webinar, more so than it is my webinar.
Yeah, thanks for the interest in our work. And it's actually quite nice to see that, very basic science work that we started off results in potential clinical applications as well.
With heart attack, one of the great difficulties in terms of raising funds to get support for more research is actually being able to tell the story. And with some of the information that you guys have provided me, there's around 18 million people die from cardiovascular disease every single year. 85% are due to a combination of heart attack or stroke or stroke. And then in a newsletter that the Baker put out, I read just last night that 40% of people who have a heart attack die on the spot. They are frightening numbers.
Yes, it's actually quite scary if you think about that. In many patients, having a heart attack is really the first symptom of having heart problems at all. And very often, as you mentioned, around 30 to 40% of patients, when they have their heart attack, they die right away. And often it's during their sleep. So we don't even know what patients or people die of. And only a few of patients who have a heart attack make it in due time to the hospital. So, which means this is a time frame, 1.5, maybe 2 hours, where we can still salvage the heart muscle tissue. And if you are too late, often we can't really help patients. We can't salvage the heart muscle.
So what are the numbers? If I have a heart attack this evening and I do make it to hospital in a reasonable time, what's the success rate for survival?
So we have quite fancy technology now, and for example, in the Alfred Hospital. So we would bring you directly to the cath lab and see whether there is a blockage of the vessel, open up that blockage and place a stent to stabilize the vessel. And so currently we can save most patients in a way that they are discharged alive from the hospital, but often, since we are too late and the transport often takes too long, there is a scar at the heart, and you will feel this as a patient when you try to do exercise, or even if you try to do normal things in the household, you will be short of breath. And that's often the symptoms that we have as a result of a heart attack.
So what's the survival rate like now by comparison to, say, in 1990, which is only 30 years ago, and it doesn't seem that long ago?
So before we had these fancy technologies, probably half of patients who were submitted to the hospital with a heart attack actually died in the hospital. Yeah? And we got so good with a lot of research, a lot of investment in our infrastructure, that we probably keep between 5 to 8% mortality now. So we can really save most lives of people that make it to the hospital. The problem is more before the hospital, that we have this out of hospital arrest. And even if typically if you do sports, you have these events when you have a heart attack. If you're lucky, people are around to do CPR and you make it in time to the hospital, then we can help you. But often this doesn't work out, and more or less the brain function is gone.
Yeah, a friend of mine was really lucky in that he was having a heart attack in his bed, and his wife had done first aid when they first had kids, dragged him off the bed, was giving CPR. Another one of the kids rang an ambulance, and he's still with us, thankfully. So he was already indebted to his wife, but now he's even more so indebted to his wife.
Yeah. So it's always good if your relatives know how to do CPR, definitely.
Yeah, absolutely. So one of the big things that causes heart attacks is plaque. You have a lot of information already on the amount of plaque that is in somebody's system, but the challenge is which plaque is the dangerous plaque?
Yeah, so the problem that we face as cardiologists is that we more or less show the lumen, so the inside of the vessel. So we see what percentage of narrowing we have, but we don't see into the wall of the artery. So we can't tell whether you have an unstable plaque or a stable plaque. So even if we do an angiogram and tell you as a patient everything looks fine, you can come back the next day with a heart attack, and probably you think you are one of the worst doctors that the person has ever seen, because he was saying the heart is okay. And that's really the problem and the frustration for us cardiologists, that we can't foresee which of these plaques is unstable, which of these plaques will cause a heart attack.
Well, in many respects, you've just answered one of our first questions from Yvonne, which was, can you please tell us about stable and unstable plaque? And is there anything we can do to prevent the plaque? So this is the key to your research. And Simon Q has followed up with a question which really cuts to the issue with your research that you're doing and the technology that you're developing. And Simon has asked, is there work being done to use the near infrared light through a non-invasive device similar to a CT scan?
Yeah, so this near infrared light technology that we developed, that uses light to scan people, and we don't have yet the technology to do this in a scanner like a CT yet. So currently there's a lot of development going in this space, and that is the reason why we developed a catheter that goes into the coronary artery and shines light from within the artery and collects the light within the artery, and that's currently the best technology that is available for this.
So what is the work that you've been doing to develop the technology and take to the next step and hopefully make us able to identify those unstable plaques in the future?
The work that we did is actually a typical example how discoveries often happen by chance. So we worked for quite a while to develop a mouse model that kind of reflects what we see in patients, these unstable plaques that rupture and cause clotting and blockage of the arteries. And then we did use this model and put it on a near infrared scanner, so a light scanner more or less. And then suddenly this area that was unstable started to light up like a Christmas tree. And we were quite surprised and initially thought it must be the student who did a mistake. And so we nearly blamed him, and he insisted that he didn't do any mistake. And so we checked it again. And indeed, the next mouse had the same phenomenon. And then to be sure that it's not only something that we see in mice, we looked at plaques from patients who had a stroke, where we could obtain the plaque that sits in the carotid artery in the neck. And there we found exactly the same thing, that it really did light up like a Christmas tree. Yeah? And that finding was kind of the major discovery, and we got a patent on that finding. And this is the basis of the work that we currently try to develop and make it to a technology that we can use in the hospital.
It was interesting hearing you talk about, we thought it was a mistake at first. I can't remember which great inventor it was of the 18th or 19th century, but he was quoted as saying, "I've never made any mistakes. I've just worked out another way that isn't the right way to do it."
Yeah, that's right. Yeah, but
that would be the key to research.
Yeah, it's I think so. Yeah, because a lot of the research are, or the successful things are discoveries by chance, that you didn't plan for. And it's a good scientist is always aware of, checking outcomes and see whether the hypothesis that they have initially really fits, and if not, work on different mechanisms.
Yeah. I spoke at the start about my purpose for being here and my family connection. And I'm always interested to know from your perspective as a professor doing research here, what's the underlying motivation for you?
Yeah, so it's an interesting question. I was always interested in doing research and science. So when I was at high school, I thought I will become a scientist and maybe physics, because I was quite good in school in physics. So I thought this is an area to go for. And then my father, actually, who was from the generation who they did a lot of smoking as part of their lifestyle choice. And so he had a heart attack early on, and I was 17 when I was in high school, and I visited him often in the hospital then, and I saw how important technology is to really keep him alive and also to help him on the long term. And this was the first time that I was introduced to medicine. And then I decided really to study medicine with the idea to do research. And already during medical school, most of my time I actually spent on doing research. I often had to ask my friends to sign for me in the courses because I was doing experiments. And the same was true when I was doing my clinical training. Often in the evening or late night, I spent the time in the lab, and I was always interested in research.
Yeah, there's certainly easier ways to make money if that was a motivator. So you've got to have that underlying motivation. And as you and I spoke yesterday, there was a great post that was put up on one of the social media platforms about 6 months ago throughout the pandemic with coronavirus. And it was along the lines of, this is what a researcher is paid. This is what Cristiano Ronaldo is paid. Go and see Ronaldo for your vaccine.
Yeah, that's right. Yeah.
Which I thought was a great quote.
Yeah.
We've got a couple of questions that have come in before this was actually launched, the webinar, but we're happy to keep taking questions as we go along. But in terms of the next steps, the next stages for you in developing this technology, what do you need to do and what's the next phase for you?
So we have now the design of this guide wire that we try to develop. Now the difficulty for us and the challenge really is to get the funding and to do clinical trials, which are quite expensive. And we calculated that we probably need 5 to 7 million Australian dollars to get this device into the heart of patients and use it really in patients. And this is quite a big challenge because we often have good outcomes in basic research, but to get the money to develop something into clinical practice, that is quite difficult. And we try to obtain funding by different state or federal government institutions, but we also try to get funding from the US and other countries as well.
It's been amazing to see how much funding can do for actually making progress in science when it came to developing the vaccine for the coronavirus.
Yeah, I mean, that's a fantastic example. And I think more and more people realize the importance of science, seeing, how the understanding of COVID is really dependent on scientific work. The treatment, you could see online more or less how new treatment strategies have been developed, and the vaccine development. This is something a few years ago, we calculated 6 to 7 years for the development of a vaccine, and now it has been developed in such a short time. And the mRNA technology, so the Pfizer and the Moderna vaccine, for example, these are really technologies that are based on PhDs that people did over 20 years ago. Yeah? So the technology took a long time to be just ready for this pandemic in a way. Yeah.
Yeah.
And
wow.
so it's not something that you needed a lot of basic science research to get at that stage that you can really jump on and develop the vaccine.
Yeah, it needed the foundation to be able to build the penthouse apartment at the top of that building. Yeah,
exactly.
I've got a question from Jeff Leach, but before we get to that one, another good follow-up question from Simon Q is: will this new device, the near infrared light, become standard kit for cardiologists in the future?
So that's our plan. When you do an angiogram, that we use this technology and scan the coronary arteries. And if you have an unstable plaque, then we would either stent that or give you appropriate medical therapy.
Yeah. And Jeff has asked a question about long-time endurance athletes and their risk to having cardiac issues. Has there been anything done to help measure the impact for endurance athletes? And again, as somebody who's been a cyclist for all of his adult life, I'm interested in the answer.
Yeah. So this is something really interesting. So we know that certain risk factors like high cholesterol or hypertension or obesity, increases the risk of having a heart attack. But at the same time, we know that around 1/4 of patients who have a heart attack, they don't have any risk factor at all. And this is the group where athletes would fit in. And so this is currently really the big problem that we can't foresee of whether an athlete with 50 years of age, for example, has some plaques sitting in their coronary arteries that are unstable. Yeah. So that it's a thing, a situation that we don't have a solution for at the moment.
Yeah.
And this technology at the moment allows to look into the coronary arteries when you are in the cath lab, but the long term would be to have a scanner that is based on light.
So potentially in that context of a fit athlete or just somebody that is, fit general population, you could actually have low levels of plaque, but it only takes a little bit of unstable plaque.
Yeah. That's the problem, and we can't currently, without this technology, we can't foresee whether it's ruptured. So it's kind of, it's like walking around with an internal bomb, and you never know when it goes off or whether it goes off at all. That's the comparison probably, and it's kind of scary if you think how many people walk around with this situation, and it can happen any moment, more or less.
Yeah, this question is slightly off from the research that you've been doing in terms of this technology you're developing, but it comes from somebody in our audience, and it resonates with me because my mother, having lost her father and her 2 brothers to heart attacks, was always really conscious about cholesterol. And we always, got regular cholesterol checks even as kids. And this question is, statins reduce cholesterol, but do little to reduce mortality. Comment, please.
So statins reduce the cholesterol levels quite dramatically, and we know the lower the cholesterol, the lower is the chance that these plaque ruptures. So they stabilize plaques. And what we do, for example, when we have a patient with a heart attack, we give high dose statins, even without checking the cholesterol. Even when you have a normal cholesterol, we know that statins stabilize plaques. And they are currently the only approved drugs where we know that they stabilize plaques. And so we measured this in our models as well, and we can show that there is less near infrared light emission when we treat animals, for example, with statins.
Yeah, so a question that came in before the webinar got underway from June was around coronary artery disease or unstable plaque, and how would a person know if they are vulnerable? Is unstable plaque something that is genetic, or is that another element that results in one family having multiple heart attacks?
So the 3/4 of the patients have clearly identifiable risk factors, and so we can help them. So smoking or blood pressure and these things. But 1/5 of all, or 1/4 of all patients, we don't find classical risk factors. We assume these are genetic factors that we have not yet identified. So, for example, in your family, you might have 1 or 2 genes that causes this issue, and so it might be a reasonable thing to get checks as well.
Yeah, I am super vigilant, I can assure you. And a question out of pure self-interest, is a glass of wine, red wine, okay regularly?
So we thought always, for a long time, we recommended one regular glass of wine to be cardioprotective. Now, in hindsight, we looked at all these studies, and it looks like they might not have reported the correct data. And so patients who had a heart attack, when we get asked, do we recommend alcohol? We say, no, we don't recommend it, but we don't, at the same time, we don't say that it's harmful to have a glass of wine. So the recommendations have changed of actively saying to patients, you should drink, 1 glass of wine per day. We say now, if you enjoy it, it's fine, but it's not medically recommended.
Well, I'll keep it to weekends then.
Yeah.
This is a good question that has come in from Eric M. Will you seek people who have survived a heart attack to use them in trials?
Yeah, so this is exactly the group of patients we are looking at. So we will bring patients to the cath lab, open the vessel when they come in with a heart attack, and then we screen the other vessels, whether they have unstable plaques there, and we treat them. So this is the first step. Yeah.
Okay. And another question that came in before the webinar got underway, and this was from Margaret. Could this procedure also prevent people who suffer from angina?
Yeah, angina is caused by a narrowing of the coronary arteries, and that's what we already do. When we do an angiogram, we check for narrowings, and then we would stent or balloon in that area, or would recommend a bypass operation. So that is to get rid of the angina. And so these unstable plaques often don't cause any angina. So you wouldn't have chest pain when you do exercise typically. So they are smaller. They don't cause a narrowing typically. They just rupture and then cause the heart attack.
Okay. And then what about in terms of stroke?
A stroke is similar when you have a plaque in your carotid artery and that ruptures, and then parts of the clots that develop there go into the brain and block the perfusion of the brain. So the same medication that we use for the prevention of heart attacks work for the prevention of strokes.
Okay, this is a question from Ron, and when I read this question, Ron, all I can think about is soft cheeses, camemberts, bries, etc., which is another one of my vices. Is the advice changing in relation to saturated fat intake?
So that's a good question, really. There's a lot of controversy around there, and I think this is the butter margarine controversy. And the recommendation is still, keep it at a lower level. So if you have butter, don't overdo it. And that's probably, it's all within reason, I think.
Yeah,
but recommendation.
Fresh sourdough with a little bit of butter. It's one of life's pleasures.
Yeah, that's right.
It's another question coming from an anonymous member of the audience. What value does coronary calcium score play in making plaque risks visible?
Yeah, so this is a technology where we use a CT scan. So we measure the calcium sitting in the coronary arteries, and we know the more calcium you have, the higher is the risk that your coronary arteries have atherosclerosis. But unfortunately, calcium itself is not a measure of plaque instability. So we cannot use that technology to predict whether someone has immediately an unstable plaque and has the risk to develop a heart attack.
Okay, the same person asked a second part to that question, and there's vitamin K2 supplementation that help with directing calcium to the bones and away from the blood vessels.
Yeah, so this goes in the same direction that calcification. So the calcium in these plaques make plaques probably more stable. They are. It's not associated to instability. So that's the problem, that we can't use that medication or that prophylaxis to stabilize plaques.
Okay, Simon Q again. He's been asking some good questions. Simon, maybe next time you host the webinar. Can Dr. Peter please explain the microbubbles technology that is in development And will this decrease the chance of patients developing irreversible damage to the heart or brain?
Yeah. So this microbubble technology is a development that goes in the same direction. We would like to identify the plaques that are unstable, and we kind of couple these microbubbles with markers that recognize plaque instability, and then we follow them with ultrasound. And the long-term aim is also to detect plaque instability and to prevent this.
Yeah, okay. Eloise has asked a question. I'm not sure whether you touched on this earlier or not, but I'll ask it again anyway. How will the new technology differentiate between stable and unstable plaques?
So we will shine a near-infrared light on plaques in the coronary artery, and the moment we get a autofluorescence, so we get a reflection of a specific wavelength, we know that this is an unstable plaque, and then we would stent it or treat with aggressive medical therapy.
What can I do to reduce the level of plaque that I have in my system?
So the general advices are that you should reduce your risk factors, but also have a healthy lifestyle with a lot of exercise. I think that's probably the most important advice. Do a lot of cycling, obviously.
Tick.
and every other exercise that you can do, and prevent obesity. That's currently the major driver in Western societies, that we more and more develop a sedentary lifestyle and don't have enough exercise.
Okay, so in a follow-up to that in terms of reducing plaque, Jeff Leach has asked another question. What is the current thinking about plaque regression? Can unstable gooey plaques be drained rather than stented?
Yeah, so so currently there is a development going on that plaques can be stabilized medically. So there are several anti-inflammatory drugs like colchicine, for example, that are currently tested, that we use for gout treatment. So the inflammation that you have in your toes, for example, are treated with colchicine, and we are currently testing, and this is done in Australia. It's one of the big trials, or several big trials that we are doing and have done already, to show that colchicine stabilizes plaque. That is one example. There are also more expensive therapies. So colchicine is very inexpensive, which would be a big advantage. But there are also more expensive therapies that reduce inflammation, and that seems to stabilize plaques as well.
Okay, and Kay has asked a question. She's made a comment here in the chat room, but I've managed to find it. Can this technology assist in identifying aortic aneurysm?
Probably not directly. So the aortic aneurysm can be relatively easy identified by ultrasound or CT. So you wouldn't need this kind of technology.
Okay. Vicky has asked a question of inflammation. Doesn't inflammation cause unstable plaques to rupture? If this is the case, shouldn't the focus be on diminishing inflammation?
Yeah, exactly. That's so the inflammation, for example, if you are obese, it looks like the body is in a pro-inflammatory state that causes plaque instability. And we currently test this hypothesis when we reduce inflammation, that we can stabilize plaques. And this is something that is relatively new, and only recent trials are going in this direction.
Okay, a question from Ron. What's more important to reduce heart disease, lowering triglyceride or LDL?
The LDL clearly is, there are lots of studies that can show this, and statins and other drugs that can lower LDL, and they are associated with plaque stabilization.
Okay, so importantly, to get you the money that you need to keep more people alive, what's the role that federal and state governments can play in this?
So it's actually, we were quite lucky to get some funding. The initial funding that we had for this technology came from the federal government. But now the difficulty is really to get this path to commercialization, to bring it into life in patients. And that's something the government is recognizing now, that there is kind of a valley of death, we call this often, between basic science research and then actually getting the application done and kind of developed for patients. And that that value of death is something the government has recognized is a big problem, and there are more and more funding opportunities in this direction. But it's still, when you see how many fantastic scientists we have here in Australia and a lot of technology is developed, it's still a major need to have funding, and I think philanthropic funding plays a major role in this.
Yeah, how much of your time is taken away from actually doing the research and working as a cardiologist and focusing on raising the funding?
Yeah, so when you look at the time, that shows you a bit the difficulty to get funding. So we spend probably a third of our time to write grant applications and ask for funding, and the success rate is very low. So this is something for many scientists in Australia that is quite difficult to deal with, that we have to spend so much time, and the amount of money that is generally available is not high. And when you compare it to other countries, there's probably much more basic science funding available in most developed countries, and that's something we try to convince the government to invest more. And I think currently everybody realizes how important science is, and we hope that the government reacts on this and invests more in science as well.
I'm sure when you were a 17-year-old and your father had a heart attack and you started going down that path of pursuing this career, writing funding applications wasn't part of it that was high up on your list of priorities.
Yeah. And the more senior you get, the more grant applications you write, unfortunately.
Another question from Anonymous is, which guidelines would you recommend using to assess blood cholesterol and blood pressure if you were not able to do a CVD risk profile?
Also, I think that GPs manage this very well in Australia. So it's really something you should approach your GP with, and because it's a matter of monitoring the effects of medication as well.
Yeah. Okay. And Ron has asked, what's the best way to reduce inflammation?
So currently, the drugs that we have, they are not approved yet. So this is still in the trial stage. And in general, we don't have major tools available to reduce inflammation that would not be too aggressive. And so I think a general healthy lifestyle that is probably helping you to reduce the inflammatory state.
Yeah, a question from Jenny, which is probably cutting to the need for further development on the technology and more funding for you guys to do your work. Where are the sites of unstable plaque? And what does that cause a challenge for this technology to be able to work? You spoke about infrared up, around the neck and so on to prevent strokes a lot easier. But yeah, where are the key sites?
So the key sites are in the arteries that support the heart with blood and oxygen. So, and typically it's the area that is close to the aorta. So just when the arteries come off the aorta, the bigger arteries in the vessel. So we even know, some spots that we find often, we call them widow maker, because we know if there is a plaque rupture at that particular area, that's where most people die right away when they have a plaque rupture there.
Okay. Yeah. So finally, before we wrap up, what are the next steps for you?
So currently, as mentioned, we spend a lot of time to ask for funding, and we have the engineering currently going on, and we are planning the clinical trial to test this device in patients.
Yeah. And so how can we, as those of us in the audience in the webinar, help you raise the awareness of the need to get funding for this technology?
I think this is quite an important question, because when we compare it with other areas of medicine, people often think that in the heart field, there's enough funding. You don't actually need to help and fund research, but it's actually the opposite, that when you look at the percentage of mortality, so it's around 50% of us kind of die on a heart complication at some stage, and heart attacks, 1/5 of us directly will die of having a heart attack. So the numbers are huge, and this being aware or helping to increase the awareness that there is a lot of research needed for heart diseases to improve the mortality and morbidity of patients as well.
Well, the key message that I take from that all of us here on the webinar, we can become the mouthpieces to promote this cause.
Yeah.
And for the people that are here telling 2 or 3 people, and then that multiplies, that will raise the awareness for the need for more money to do more research to save more lives. And that's the role that we can play.
Yeah, definitely. And it's an important role. A place like the Baker, really focused on heart diseases can play.
Yeah, you do amazing work. I'd like to thank everybody for joining us this afternoon. That brings us to a close for this webinar of Behind the Discoveries. We'd also like to get your feedback. As I mentioned before, we'd love to hear from you as to what was the motivation to join the webinar and where you've been tuning in from. There is a short survey that is available. We'd be really keen to get your feedback on that after listening to this webinar. And when we hang up and you get through and hopefully have a nice lunch that is reasonably healthy, low in saturated fats, and doesn't have a Pinot Noir. Also like to thank our sponsors, AIA Vitality. It wouldn't be possible without them. Professor Karlheinz, Peter, thanks for your wonderful work. And next time I see you out on the bike on Kew Boulevard, I will stop and say hello.
Yeah, thank you very much. Thanks for having me.
Thanks everybody for tuning in. Have a wonderful day.